We are live now, Doctor.
Thank you, Angela. So good evening, everybody. On behalf of Tamil Nadu Ophthalmic Association, it gives me great pleasure to invite you all for this webinar, which once again we have joined with Yosi. So once again, we've joined with Yosi to Young Ophthalmological Society of India to give you a wonderful one-on-one session on masterclass in squint examination. So these type of singular exercise actually allows us to share more knowledge, and it's particularly useful for postgraduates. And I really appreciate Niranjan and Prasanna for bringing up this topic. And also I'd like to thank all the panelists, the speaker today, and Dr. DC, of course, and all of you who have joined us today. I'm sure this will be a great, wonderful program. And fortunately, for people who have missed it, it's archived in our TNOA channel, and they can always go back and refer to this. Have a wonderful program today. And thanks once again to Yosi for taking us in. And because this, I think, is about the 6th program this year we are doing with Yosi. And I must thank Prasanna and Divkant Mishra and Niranjan for this wonderful opportunity given to TNO. Thank you.
Thank you, ma'am. A few words from our Secretary DC, sir. Sir, you're on mute.
Thank you so much, dear Prasanna and Niranjan. See, actually, what we are doing is something wonderful to see the young blood and enthusiasm. You know, it is never ending and it's always learning. As Madam said, it is there in the YouTube for everybody to learn. And one of the biggest inventions which revolutionized how we see the eye, like ophthalmoscope, is slit lamp by Goldstrand. So he has done so much in optics also. I'm sure all these young people are going to give us a lot of insights into it. Wishing the program all the very best. All the best. Thanks, Prasanna.
Thank you, sir. So Dr.
Your
Divakar,
hand,
yes, ma'am.
I think we're not able to hear him, isn't it?
No, ma'am, it was audible, ma'am.
No, it's okay. Maybe my connection is on.
No problem, ma'am. So, thanks to Dr. Divakant Mishra, sir, Dr. Nilesh, and the whole GC of Yosi as well. We are joined by Dr. Nilesh today. Dr. Divakant, sir, is traveling. A few words from Dr. Nilesh for this wonderful collaboration which is happening between TNOA and Yosi for the last 2-3 years or so.
Amrita, switch on your video. Yes, sir. Please go ahead.
Over to you, Nilesh, our Yosi secretary. Yeah.
Thank you so much, sir. And it is indeed, ma'am told that it's thanks to Yosi, but we are actually thankful to senior leaders like you who have been constantly supporting us. Like I always say, we are the young kids who want to grow up very fast. So we need to have mentors and seniors like you who encourage us and always like pamper us with all the opportunities that we can get. So thank you. And the topic itself, like I have seen the entire series that has happened in the last 6 months since ma'am has taken over as president. The topics itself are so relevant to Yosi that it becomes a resource for us. Also, we keep sharing these videos with one another in our groups as well. And all the best for today's webinar. Thank you, ma'am and sir, for the opportunity. Always great to see Amrita, ma'am. Ma'am has been, she is my mentor, Dr. Anand sir's wife, and ma'am has been a great teacher in absence, like in virtually. So thank you, ma'am, for being here. Thank you.
Thank you, Nilesh.
Thank you, Nilesh.
Yeah, with that, let us just start this proceedings, TNOA in association with Yosi. So this is the class on squint examination that we are going to have today with Dr. Pooja Patel as the speaker with a young panel as well. So this team came into force 3 years back when we started doing multiple webinars with the QR codes here, which you can scan and go back as well with cumulative of 12,000 views as such. And this was a dynamic team again under Sujata ma'am's leadership, started a webinar every month with conferences. The YO team came with every conferences count. Was the first webinar that we did in August, the same month as Madam took over. And we had the second one on artificial intelligence aiming in a global way, which was again one of the well-viewed webinars. Then we went into imaging, where we did dissect all imaging in extreme detail. And then we had the video archiving, video editing, and all the tips and tricks. Again, one of the international capsule webinars. And that is when we started moving towards individual capsules, where we had one on oculoplasty, structured clinical review. These are things which an exam going resident and PG would really benefit, followed by gonioscopy. So the gonioscopy class also was well received with a lot of video based teaching, with succinct 40-minute lecture with the dissection altogether, keeping it very precise. So in that continuation, here we are with the Squint examination. So again, thanks to our president Sujata ma'am, secretary DC sir, Dr. Devakan Mishra, Dr. Nilesh from Yosi. Again, two persons who have always been a pillar for the last 2-3 capsules, and Niranjan again goes beyond. Dr. Lippi has always helped in coordinating the Yosi resources. So definitely, I have to say it, and she has been very, very instrumental in bringing the Yosi resources on board for these modules and made the job easier. And Niranjan has been the pillar in bringing the local resources to make it a complete blend of a TNOA flavor with the Yosi punch. So with that, I would hand it over to Niranjan and Lippi, and I would be convening along with them. Dr. Prasanna Venkatesh Ramesh. Over to you, Lippi and Niranjan, for the proceedings.
Yeah, 1 minute, Prashna. I mean, I mentioned about the slate, but I wanted to mention today,
Yes,
I
sir.
think Squint is better called as strabismus. I think that's what they do that, whether it's perlighting, isn't it, Amrita? Yeah, so anyway, but that is, come a long way from those days where Squint was not at all part of UG. Now they keep in the exams also. And these young people, they have faced so much of Squint. I'm sure they'll give wonderful insights into Squint and Squint examination. All the best to all of you.
Thank you, sir. Thank you once again, sir.
Thank you.
With that, handing it over to our moderators for the 7th episode, or rather the 8th episode after our new tenure as took over, Madam as President. Over to Niranjan, Karthik, and Lippi to start the proceedings.
Thank you so much, sir. Good evening, everyone. The speaker for today's webinar is Dr. Pooja Patel. She is a consultant at ASG Eye Hospital, Surat, and she is the master for today's master class. We have a stellar panel today with us, Dr. Aditi Pachori. She is currently a consultant at Kaushalya Devi Eye Institute, Pilibhit, and also a visiting consultant in Bareilly, Uttar Pradesh. Dr. Aishwarya Rathod, she is the medical director at ARK Eye and Laser Center, Rajkot, and one of the pillar in cataract focus group, Team Yosi. Dr. Amrita, she is currently at Arvind Eye Hospital, Coimbatore, Tamil Nadu. Dr. Rasina Athik, she is currently a pediatric ophthalmologist at Fatima Eye Clinic, Chennai. And Dr. Shruti Ravi, she is a consultant at Arvind Eye Hospital, Coimbatore. So I welcome you all the panelists and speaker. And I request Dr. Pooja to please start sharing her slides and give us insights on the examination of Squint.
Thank you so much, Lippi. Good evening, everyone. First of all, I'd like to thank the entire team of TNOA and Yosi for this wonderful opportunity. And I hope by the end of this session, our residents are confident enough to carry out the strabismus examination. Just wait a second. Are slides visible?
Yes.
So as we all know that squint is also known as the strabismus. It's a condition where the two eyes are not aligned in the same direction. While one eye looks straight ahead, the other may turn inward, outward, upward, or downward. So now the squint can be apparent squint, latent squint, or a manifest squint. Manifest squint can further be divided into the concomitant squint and the paralytic squint. Concomitant squint is where the angle of
I think
deviation.
screen has stopped sharing. Screen is not visible.
Okay, wait.
Are you presenting from iPad or something?
Initially, the screen was visible. Maybe
You can share again now.
Yeah.
Okay.
You can share again.
Is it visible now?
Yeah.
Yes.
Okay. So moving further with the squint examination, we will cover everything step by step. So squint examination start the minute patient enters our OPD. History taking is utmost important as every other clinical cases. We first start with the birth history. Was the child born preterm? What was the birth weight? Whether it was a low birth weight child with the NICU admission? Was forceps or any instruments were used during the delivery? Family history is again very important. It is similar condition in any family member. Is there a history of strong glasses being used in any or by the any other family member? A positive family history of the squint also significantly raises the index of suspicion. We ask about the developmental milestones. In uneducated parents, it may be missed sometimes, but squint is very common with the gross developmental delay. Then comes a very important question. When did the parents first notice the squint? Was the squint present since the birth? Did it develop during the first 6 months of life? Whether it is visible all throughout the day or whether it is visible only when the child gets tired, irritated, and when the child is not concentrating. We must also ask about the associated systemic conditions like Down syndrome or any other neurological conditions. And we must always ask about any prior treatment for the strabismus in the forms of glasses, patching, or if any other squint surgery was previously done. And we can always ask parents to show the pictures if the child, if they are not sure about the timeline of the development of the squint. So squint examination starts when the patient enters our OPD, and before even patient gets seated, we should observe them. So as you can see in this first picture, patient is showing the right face turn. So look for the abnormal head posture, both for the distance and near. Look for the position of the lid and look for the any peculiar facial features. As you can see in this last picture, child is elevating both the lids because of the severe ptosis and is a case of the CFEOM. Now we need to also look for certain conditions when parent present us with the complaint of deviation of the eyes, but it is not a manifest squint, it is a apparent squint, that is a pseudo squint. As you can see in this first picture, because of the broad nasal bridge combined with the prominent apicanthal fold, it appears as a child is having an esotropia, but while pinching the nose, you can see the sclera of the both the sides medial aspect is visible and child is not having the actual squint. Now in this image, you can see the left eye appears a ptotic lid, but while we cover the right eye, the ptosis disappears as the left eye takes the fixation. So this occurs because of the relative hypotropic position of the left eye and known as a pseudotosis. So before labeling is it as a ptosis, we should perform the covered test. And we should also look for the any abnormal facial features, frontal bossing, craniosynostosis, abnormal position and placement of the globe, and mongoloid and anti-mongoloid slants, because the slants are often associated with the patent strabismus and thus help in the management of the case. So squint examination does not require any hi-fi instruments. So we can always start with the basic, a proper refraction set, a stereopsis chart, and a fusion test. Torch light is preferred, and a near fixation target should always be used instead of a torch light while asking patient to focus on the near object. Also, it is difficult to grab the attention of the child, and it is okay if we use any toys in our OPD so that we can grab the attention of the child. Apart from that, the prism bar or the loose prisms are required for assessment of the amount of the prisms. So starting with the visual acuity assessment for the adults and children above 4 to 5 years of the age, Snellen's and ETDRS charts are preferred. But for the children less than 4 years age or the children of the preschool age group, we can prefer the picture-based chart like the Allen picture chart and the K picture chart. And for those below the 2 years, we use the Leah symbols and the cat card test. And for the measurement of the visual acuity in the infants, optokinetic nystagmus drum, Teller acuity cards, and the visual evoked potentials are used. So refraction is again at most important, proper cyclopelagic Refraction should be performed in the children less than 6 years of the age with the esotropia and the hypertropia. It is advisable to use a strong cycloplegic agent like the 1% atropine. After performing the proper cycloplegic refraction, appropriate glasses should be prescribed, and a proper fundus examination should be done to rule out any underlying macular pathology.
It
At
has
this,
stopped sharing again. Sorry to interrupt. Can you share?
that's
Yeah.
yes, I.
Yes, visible now.
Yeah, so after the cycloplegic refraction and prescription of the glasses, we need to rule out the any macular pathology and the gross reason for the amblyopia. So the thorough fundus examination should be done, and even the fixation should be checked. It is always good idea to perform the sensory evaluation before the motor evaluation, because in the certain cases of the squint, like the intermittent strabismus, the fusion mechanism is very labile and can be disrupted the moment we occlude the eye. So to evaluate the sensory examination, it is divided into the two parts, the stereopsis examination and the test for the fusion. For stereopsis, we usually perform the and routinely use the Rendot test, Titmus fly test, and the Lang test. And collectively, they measure the stereopsis from the 40 arc seconds up to the gross stereopsis of 3000 arc seconds. These are all the tests for the near stereopsis. Ideally, the stereopsis for the distant should also be checked, but we are not routinely performing that. Just giving you a brief idea how to perform the Rendot stereo test. So first, we should always ask the patient to wear their proper refractive correction if they are having any. Then the polarized glasses are worn by the patient, and patient is asked to look for any object which he or she finds different. And that's how we can check for the stereopsis. To test for the fusion, we usually perform the Worth-Fordos test, Bagolini's test, and four-prism best out test. To perform the Worth-Fordos test, the patient is seated into the darkened room. Red and green glasses are worn, red glass over the right eye and the left green glass over the left eye. Normally, patient sees the four dot. In case of the NRC, when patient is only able to see the two red dots, left eye is suppressed. When the patient can see three green dots, right eye is suppressed. And in case when the patient can see total five dots, it can be suggestive of the diplopia, which can be crossed and uncrossed. Moving further to motor evaluation is broadly classified into the qualitative and quantitative. Qualitative assessment tells us what the patient has, that is the type, direction, and nature of the squint, while as the quantitative assessment measures how much deviation is present. And this is essential for planning the management of the strabismus. Now, I know that as a resident, terms like cover, uncover, alternate cover test, latent, and manifest can all get very confusing. So let us talk about each one by one. So what is cover test? In cover test, one eye is covered, that is the fixating eye is covered, and interpretation is dependent on the movement of the other eye, that is a non-covered eye. And the other eye, which is not covered, can move outward, inward, upward, downward. Looking from this example, as you can see in the image, here, when the right eye is occluded, right eye is a fixating eye. When the right eye is occluded, the left eye moves from outward to inward, which is inward to outward, which is like esotropia. In case of the exotropia, the non-fixating eye moves inward to take up the fixation. Similarly, in the hypertropia, eye moves from upward to downward. And in case of the hypotropia, eye moves from downward to upward. So here we will see with the video, as you can see, the corneal light reflex is in the center. While covering the left eye, there is a no movement in the eye. Again, check for the same movement of the right eye because left eye is being covered and there is no movement in the right eye. So this is showing the normal ocular alignment. On covering the right eye, there is no movement in the left eye. So when there is no movement on the cover test, it suggests the normal ocular alignment. This is a case of the esotropia. Left eye is moved inward. So while covering the right fixating eye, left eye moves from inward to outward and takes a fixation. At the same time, when the Non-fixating eye cover, there is no movement in the right eye. Similarly, looking at the case of the exotropia, when the fixating right eye is covered, left eye will take up the fixation and it will move from out to in. And if we cover the non-fixating eye at that time, that is the left eye, there will not be any movement in the right eye. So cover test gives us an idea of the tropia or the manifest squint. Now coming to the uncover test. In uncover test, we check the movement of the eye under the cover. So cover one eye, then uncover it and then check the movement of the same eye. We will see with the example here. When we are covering the left eye, the eye under the cover, that is the left eye, moves inward, and upon uncovering, it moves outward. So this is a case of the esophoria. Similarly, when the case of the exophoria, when the left eye is covered, the eye under the cover moves outward, and upon uncovering, it moves inward to take the fixation. So this is a case of the exophoria. Again, in this video, look carefully the right eye. Right now, the right eye is occluded. The minute the right eye is uncovered, look for the movement of the deviation and the movement of the eye.
Dr. Pooja, the screen again got
Yeah.
a bit dislodged. Yeah.
Okay, wait.
Yeah. Just share your screen again. Yeah. Yeah. It got a bit dislodged. Yeah.
So we were
Yeah.
looking at the
Now it's
uncover
visible.
test.
Yeah. Now it's
Okay.
visible. Yeah.
Yes, so I will just play this video. So we are looking for the movement of the right eye under the cover. So right eye is covered right now, and upon uncovering the right eye, the eye moved from outward to inward. Show that this was the case of the exophoria. So uncover test gives us an idea of the phoria or the latent squint. Similarly, I am repeating the test in this patient to check for the presence of any squint. So when the right eye is covered, we are looking at the movement of the left eye, and left eye is covered, we check for the movement of the right eye. There is no apparent movement. So this is showing the normal ocular alignment. Just to demonstrate and check for the phoria, I'm covering the right eye right now and checking for the movement of the right eye, and it shows no movement. So there is no latent squint as well. And we are looking here at the alternate cover test. So occluder is moved briskly between the two eyes, but it should also occlude one eye for few seconds. So alternate cover test is a very strong dissociative test, and it gives an idea about total deviation, that is the phorias as well as the manifest squint. And it is more useful when done with the prism bar cover test. Coming for the quantitative test of the motor evaluation, first we will look to the Hirschberg corneal light reflex test. Here, here we will look for the first Purkinje image formed on the corneal plane, and the patient examiner should sit in front of the patient, and light reflex is shown to the patient. So here you can see in this image, uh, between the center of the pupil and the nasal canthus, the deviation of the eye is divided into the four zone. Whenever the corneal reflex falls on the pupillary margin, it corresponds to the 15-degree. So approximately 1 millimeter deviation of the corneal reflex suggests a 7 degree of the deviation, which equals to the 15 prism diopter of the deviation. So whenever the reflex falls on the pupillary margin, it is approximately 15 prism diopter. Whenever it is between the pupillary margin and the limbus, approximately 30-degree. And whenever it falls on the limbus, it is showing the 45-degree of the deviation. Whenever the corneal light reflex falls on the sclera, it is suggestive of a very large deviation. As in this image, you can see the corneal light reflex here is between the pupillary margin and the limbus. And in this case, you can see it is at the limbus. So this is approximately 45-degree of the corneal reflex deviation. Coming to the another corneal light reflex test is the Krimsky's test and modified Krimsky's test. So as we already discussed, the prerequisite for the cover test is a good vision, good fixation, at the same time, the normal ocular motility. So even in the cases of the pulses, the eye should be coming up to the midline to check for the cover test. So in the cases when there is a restriction or paralysis, when there is a poor fixation and when there is a poor vision of the eye, we can perform the Krimskis test to quantify the amount of the squint. In the cases of the Krimskis test, prism is placed in front of the non-dominant or the deviating eye. The patient fixates with the better eye, and we increase the prism power until the corneal reflex is centered in the deviating eye. While in case of the modified Krimskis test, the prism is instead placed in front of the dominant or the fixating eye, and we observe the centration of the reflex in the deviated eye. So both this test allows us to estimate the angle of deviation even when alternating fixation is not possible. Now coming to the alternate prism bar cover test, it is a gold standard for measuring the angle of the deviation. The cover is alternated briskly between the two eyes to dissociate the fixation and fusion, and prisms are added until the point of neutralization is achieved. The point of neutralization means there is no movement of the eye. We will see this with the example. Here, prisms are split between the two eyes because it is a large angle squint. And as you can see, there is no apparent movement. It is a case of the esotropia. So without the second prism, the eyes are moving from in to out. And upon placing both the prisms or the neutralizing, there is no movement of the eyes.
Your screen.
Yeah, screen again, just that.
I am so sorry. Actually,
No
I'm
worries,
not
no
able to
worries.
figure out what's happening currently.
No, it's okay. Just reshare it and just keep
Yeah,
moving.
that's all right. Okay.
Perfect.
So yes, we are checking the alternate prism cover test. The cover is alternated briskly between the two eyes. Here, this is a case of the large angle esotropia. And here it is neutralized with the two prisms, approximately 40 prism diopter. So it is a total 80 prism diopter of the esotropia. While one prism is removed, you can see the eyes are moving from in to out. And when neutralizing with the total amount of the deviation, there is no movement apparent easily seen in the eye. So alternate prism cover test gives an idea of the total deviation, that is the forias as well as tropias, while as if we do the simultaneous prism cover test, it gives just the idea about the tropia. The alternate prism bar cover test should be performed both for the distance and near, and also with and without the glasses, because in case of the refractive accommodative esotropia and in case of the near distance disparity, the deviation for the distance and near can be different. We should always remember that the apex of the prism is always towards the direction of the deviation. Base out for the esotropia and base in for the exotropia. Base down for the hypertropia and vice versa. It is an important point that the prisms of the same direction cannot be stacked upon each other, but prism of the different direction, that is for the horizontal deviation and vertical deviation, can be stacked upon each other. If we stack the prism of the same similar direction upon each other, we can have the erroneous deviation measurement. And it is also important that we also check the AC by A ratio. For the larger amount of the deviations, two prisms can be split between the two eyes. Measurement should always be done in the all 9 diagnostic position of the gaze, as well as in the head tilts for the oblique deviations. So now moving forward, we need to check for the ocular motility. So versions are the binocular conjugate movement of both the eyes. It is tested in all the 9 diagnostic position of the gaze, and following version, or even if we find any limitation of the movement, it should always be checked uniocularly. That is, adduction should always be checked in all the 9 position of the gazes. This is just to document the ocular motility as well as the amount of the squint in the each cases. This is the supra version, this is the infra version, that is the dextro version, and this is the levo version. So I basically use the 9 gaze app to document the squint, and the ocular motility. So now coming to this image, you can see the first A image here, the center of the pupil and the nasal canthus is divided into the 4 units. Similarly, it can be divided up to the lateral canthus. So here each unit depicts the limitation of the ocular movement. If the eyeball cannot cross the midline, it is the -4 limitation of the muscle, and if can reach up to here, it is a -1 limitation of the ocular movement. Similarly, it can also be checked for the obliques. Here you can see, as shown in this picture, inferior oblique is an elevator. So the scale is used for documenting the overaction and underaction of the inferior oblique. And it is again divided into the 4 units. That is the underaction of the inferior oblique, and here it is an overaction of the inferior oblique. Similarly, it can also be done for the superior oblique in this case. We will first see this right image. Here, as you can see, the left eye is not reaching up to the lateral canthus. So there is a limitation of the left eye lateral rectus, and that will be -2. And here, this is the case of the left eye DRS, and you can see there is a total globe retraction on the adduction. Moving to this next image, this is for documenting the exotropia. The patient had the V pattern of the exotropia. As here you can see, we check for the elevation and adduction, and you can see the inferior oblique is overacting. So this patient had the bilateral inferior oblique overaction. So after the motility assessment, we should do the thorough comprehensive ophthalmic evaluation. We should check for any pathology into the anterior segment, document the pupil, the reaction, check for the IOP, and also do the fundus examination. So fundus examination also help us for the documentation of the torsion. So in the cases of the oblique overaction, we can find the torsion, and torsion can be measured subjectively and objectively. Subjective method
And
of
your
the torsion is as
screen,
Screen, just now.
yeah.
Yeah, perfect.
So coming to the torsion assessment, it can be done subjectively, it can be done objectively. For subjective assessment, we use the double Maddox rod test, and for the objective measurement, we can use the indirect ophthalmoscopy and the fundus photography. So usually the macula or the fovea is present in corresponds to the lower third of the optic disc. Whenever the fovea displaces inferiorly from the line drawn from the center of the optic nerve head, it is the excyclotorsion, and the fovea displaces above this line, it is the encyclotorsion. This images of the fundus indirect ophthalmoscopy, as here you can see, even the torsion can be graded by the 1 plus 2 plus 3 plus 4 test of the extorsion. And when the fovea is displaced upwards, it is intorsion. Now I will come to some special tests which help us in identifying and the measuring the incomitant squint. Incomitant squint is one where the deviation is different in all the gazes. So we will come to each other step by step, and I will briefly mention this. So first coming to the diplopia charting. So diplopia charting is performed in a darkened room. The patient wears the red-green glasses, red glass in front of the right eye, and left eye has the green glass. We should always use a slit light source to check for the horizontal diplopia. A vertical light source is given, and for the vertical diplopia, which give the horizontal slit light source. So diplopia charting gives us an idea about the uniocular or binocular diplopia. It can also give us idea about the field of binocular single vision, and it can also give us an idea about the distance between the two images. Also, we can come to know about the crossed and uncrossed nature of the diplopia. As here we can see in this image, this is the field of the binocular single vision, and this is the field of the maximum limitation of the ocular motility. So this is an image of the left eye 6 nerve palsy. Coming to the Hess chart, let's look at the Hess chart, and the trick is knowing how to interpret these charts. The simple rule is the smaller field is the pathological eye, whether it can be paralytic or restrictive. Hess chart helps us to isolate the individual muscles, and we can always do this on the follow-up to document the improvement or deterioration over the time. Now, how do we differentiate neurogenic from the mechanical restriction? In paralytic strabismus, the affected eye shows the largest underaction in the direction of the paretic muscle, and the contralateral synergist shows the largest overaction. This is by the Hering's law. So the secondary deviation is always greater than the primary deviation. And in the mechanical or restrictive strabismus, the field is compressed and crowded, but without significant overaction of the contralateral synergist. So this is the image of the right eye, right six nerve pulse. It's coming to the last test. So this is the force duction test and force generation test. It helps us in identifying again the cause of the concomitant strabismus, that is the restrictive or the paralytic strabismus, while the force duction test evaluates the resistance to the passive movement of the globe by the examiner. The active force generation test check the force exerted by the muscle during ocular rotation. First, we need to explain the procedure to the patient. Take the consent. Topical anesthetic is injected or inserted into the Culde's set. To now coming to the video. So to check for the force duction test, the patient is asked to look into the abduction first. After grasping the conjunctiva at the limbus, patient is the eyeball is moved in the direction of the natural arc of the movement. Here, as you can see, the lateral rectus is free because the eye can be moved completely toward the nasal side. Now coming to check for the force generation test for the medial rectus. So here the nasal limbus is grasped and patient is asked to look in adduction. So we need to feel the tug. If during this movement, when the patient moves the eye inward, if we can feel the tug, it is suggestive of the force is present in that muscle. And the passive force duction test is performed into the general anesthesia, and eyeball is moved in the opposite direction of the muscle being tested. So to summarize this examination, we always first importantly take the detailed history, observe the patient while the patient walks into our chamber, take the visual acuity, give the proper cycloplegic correction, check for the sensory status of the patient, and then do the motor evaluation. Ocular motility and the complete ophthalmic examination should be done. And in the cases of the concomitant strabismus, we should perform the spatial test. Thank you.
Thank you so much, Dr. Pooja. That was beautifully covered. And squint is a very difficult topic when it comes to postgraduates. Everyone has a nightmare if they get a squint case in their exams. And I think that was beautifully covered. And residents and all the trainees are going to get a lot of benefit from this examination masterclass. So the house is open for the panelists for discussion. Firstly, I would like to ask Dr. Aishwarya, any books or any videos or on material that you would like to recommend for the residents for in order to help them for their preparation during their exams?
Hi, Lipi. Thank you. First of all, Dr. Pooja, wonderful lecture.
Thank
Yeah,
you
we
so
all
much.
have read Dr. Pradeep Sharma sir's book as one of the standard textbooks for Squint. But I would also recommend to the residents to look at least, I mean, I know one wooden is very difficult to read, but at least go through the first four chapters, because the examination chapters, the first four chapters are something that form the basis for very good examination, especially the nuances that are written, because with a wonderful lecture like this, and there are multiple YouTube channels that we can share on the chat box that I'll share right now, that can help us in see dividing the topics and helping us understand Squint one after another. One more, two more points I'd like to add to the lecture is quantifying the head posture, which I think residents don't do enough. I think quantifying the head posture is in one way a natural way of putting a prism, because if you put a protractor and find out the amount of head posture, it's like the patient is giving you a natural number or a prism without even putting a prism, how much of the deviation is there. And secondly, in what I've seen with patients pre-verbal children is that I mean, although there are multiple charts, Leah symbols and pediatric charts that help us in looking at the visual acuity in toddlers and younger children, but even if they do tell us the visual acuity, it's not reliable because they're usually not compliant. So fixation patterns in such children, especially younger pre-verbal preschool children, help a lot in deciding and helping us cross fixation patterns, preferential fixation patterns in seeing the amount of squint, because usually they'll not be, accessible to a complete examination. Otherwise, wonderful lecture, and anybody would like to anything?
Thank you, Dr. Aishwarya, for those wonderful insights. Now I'd like to request inputs from Dr. Amrita. So this is very, first of all, I would like to thank Dr. Pooja for this wonderful lecture. The thing that I was very enlightened upon was about the documentation of squint. So for all the residents out there, from my little experience, I think more than coming to a diagnosis in a case of squint, I think it all matters about how you go about evaluating it and documenting the same. So I request Amrita ma'am's inputs regarding this, please.
Yes, thank you, Dr. Niranjan. Good evening, everyone. So, for the exam point of view, I would give you certain tips to be followed during exams. So, whenever you get a squint case, first of all, don't panic about it. It's quite simple in various aspects. I can say there is a very limited amount of case which can be asked in the exams. All you have to be thorough is in these few cases, maybe 4 or 5. Like the most common and most favorite will be the advanced retraction syndrome. Other than that, it will be either a congenital esotropias or commonly intermittent exotropias. These are the most commonly asked few things. All you have to know is certain theoretical aspects of these cases. Rarely they can ask about Brown syndrome or a monocular elevation deficit. These are the things which you have to learn for an exam point of view. And whenever you're appearing for a practical exam, make sure you spend less time for history taking, because you need a more time for examination of a squint. So basically, taking a history is also quite common for all these cases. As Dr. Pooja already suggested, all you have to do is take some previous family history and previous interventions, anything done, onset, association of diplopia, few points are which is common for all the cases. So all you need to know is a basic squint. You should know a protocol. So following that, you should spend more time on examination. So certain things which you have to remember during evaluation of a squint is that if you are given a chance to do the motor evaluation and as well as the sensory evaluation, always do sensory evaluation first, because if you do motor evaluation, it will break the fusion and you may not get the proper sensory evaluation results. So, but most of the time sensory evaluation will not be kept in the exam, so you don't have to really worry. One more point you have to always keep in mind is whenever you're doing a squint evaluation and whenever you're measuring a squint, always make the patient wear the correct refractive correction. They should be wearing the glasses during your measurements. So, you need not do all 9 positions of the gaze because you will not have that much of time. You can do distance and near deviations. This will be sufficient in case of concomitant strabismus. When it comes to incomitant strabismus, always remember there is a primary deviation as well as the secondary deviation, and you have to measure the primary deviation. In order to measure primary deviation, always remember you should keep the prisms in front of the problematic eye, and patient will be fixating with the normal eye. That will give the primary deviation. So if you don't have sufficient time, you try to do the primary deviation, and if you have sufficient time, you can also do the secondary deviation. In order to measure secondary deviation, you have to keep the prisms on the normal eye and patient will be fixating with the problematic eye. And you know that in case of incomitant strabismus, the secondary deviation is always more than the primary deviation. So these are the few tips I would like to give you. And also, as already mentioned, you don't have to really give the diagnosis, but you have to give a proper points at the end of this thing. You can say that I have such and such a patient. I have noticed an exodeviation in this eye. And you can also suggest about any associations, like if there is a pattern or if there's any dissociated vertical deviation associated with the primary deviation, you should always mention that in the diagnosis. And also you can also mention about any dominance present, either a right eye dominance or a left eye dominance. Yeah, that's it from my side.
Thank you so much, ma'am. I'm sure all the residents must have taken note of the important points that you've shared with us. Thank you so much. My next question is for Dr. Aditi. So we've been hearing enough and more about the strong link between refraction and squint. So if you could just throw light on how they both go hand in hand and how residents can understand the relation between the two, ma'am.
So when we see a patient that is walking into the clinic with an esotropia, you need to do the first utmost thing is go for a good dilated refraction. You need to do the retinoscopy and you need to make sure that the retinoscopy is being done in a proper way. If the child is under the age of 2 years, go with atropine. Above that, go with homatropine, and then you can go with the basic dilator after that. The point is you need to see the accommodation by AC by A ratio, accommodation convergence with accommodation ratio. If the child on wearing glasses, the convergence relaxes a bit, then the ESO is because of high convergence. So you need to make the patient wear glasses and that will relieve a bit of esotropia in that. And the case in progress without some surgeries required at utmost importance. So retinoscopy is the main point in esotropias. Then there is a point when you need to see the fundus too, because in stimulus deprivation phases, the eye majorly goes into exotropias. So you need to see the fundus whether there is something that is causing any macular pathologies or something. So the exo is not there. Yeah.
Thank you.
I just want to add one point to whatever Dr. Aditi said. Always you do not use a torchlight for examination, because whenever you're using a torchlight, you might tend to miss on the accommodative component. So you need not have an accommodation to just point. So child will just look like orthophoric. Always use a target. So whenever the child tries to accommodate at a target, that is when you notice a accommodative esotropia. So it's always good to carry a accommodative target for your exams. Never use torch to do this. Only for Hirschberg test you use the torchlight. Other than that, all tests has to be done with an accommodative target. Otherwise, you will miss on these accommodative esotropias.
If at times you do not have an accommodative target, you can use the eye drops. The labeling on the eye drops, you can ask the child to focus on the big patterns. If A, D, any letter is written, the patient can focus on that and you can make it work.
So I think these are questions residents are bound to expect if which is the one place where you would use torch examination. So I guess that is also a point to be noted. Now, moving on to Dr. Rasina ma'am, a very important dilemma that still persists would be when to operate in case of squint. So we would like to hear your inputs on your take on how and when should one operate on different types of squints. Of course, just maybe an overview for the residents.
So, congrats, Dr. Pooja. She has narrated beautifully, step by step, how to go about a squint case. That is, I think it will be useful for the residents as well. So, when to operate? This is a common question when parents come into a clinic. When to operate, ma'am? Should we do it immediately? Even if you say if you want to do it immediately, they will never accept this. So we have to first quantify how much is a squint. If it is very only lesser deviation, we can give orthoptic exercises. It will get corrected in orthoptic exercises in most of the intermittent squint. When it is a constant squint and they have major deviations, if it is more than 35 PD, when it is more than 40 PD, where surgery is the only mandatory thing, then we have to go to surgery as soon as possible, as early as possible, because then only the stereopsis will be maintained. after surgery, we can bring the stereopsis to a better control. So always in congenital esotropy also, we have to do the surgery as early as possible. So depending upon how we quantify the squint and the type of squint, the timing of surgery also differs.
Thank you, ma'am.
Ma'am, is there any age limit, like lower age limit, when can we operate for squint?
I don't think there is any lower age limit, but during a residency in Aravind, even at 2 years for a congenital esotropia, we have been operated.
Okay, ma'am. Thank
Yeah,
you.
can I add to that?
Yes, ma'am. Yes, please.
Yeah, it is usually suggested that esotropias has to be operated as early as possible. That will be before 2 years of age, because that is when the child can assume a binocular single vision. Any surgery which is done after 2 years of age is mostly of a cosmetic correction, and regaining the binocularity and normal stereops will be little less. So we would suggest between 9 months to 2 years of age for congenital esotropias. Whereas when it comes to exotropias, constant XT, again, it is same as the congenital esotropias. But when it comes to intermittent exotropias, you have to see and you have to grade the intermittent exotropia. So if it is a small angle with a good BSV and stereopsis, you can wait and you can put the child on orthoptic exercises. And there are certain indications to do surgery in case of intermittent exotropia, like drop in stereopsis, drop in binocular vision. If the child is manifesting very often, that is poor control of intermittent exotropias, or if if it is a very large angle, these are the indications. When the child reaches these indications, that is when we plan to operate an intermittent exotropia. And we should also remember one important point before surgery is that always do a cycloplegic refraction and give a full refractive correction, because many of the squints, the angle will vary with the best corrective glasses. So first and foremost step will be cycloplegic refraction and prescription of glasses, and then subsequently you follow up the child and then decide on the surgery. And also treatment of amblyopia. These two things comes first, followed by surgery.
Thank you, ma'am.
Thank you, ma'am. So I guess there goes the thumb rule of when to go about operating. Thank you, ma'am, for your inputs. Moving on to Dr. Shruti, this one is for those who are about to finish their residency and the young ophthalmologists. It is often said that it requires a separate temperament and patience to take up pediatric ophthalmology as a fellowship, So in this aspect, I would like everybody's inputs, but we'll hear from Dr. Shruti, who's recently completed her fellowship from prestigious Arvind Coimbatore. Over to you, Dr. Shruti.
Thank you, Dr. Niranjan. Actually, it is very true because in general, all doctors, we require a lot of patience for examination. But especially when you examine pediatric patients, you require much more patience because they don't cooperate as we expect them to. It is always like we have to go with their pace, we have to go with them, and we have to make sure that we are their friends and they are not scared of us and everything. Only then they'll cooperate for our examination. The moment they enter and they are scared of us, they start crying, and we will not be able to proceed with the squint evaluation. And especially squint requires a lot of cooperation from a child. So that's why you have to have a lot of toys, some video images or something, so that the child gets a friendly environment when they are with us. And only then you can be able to proceed with the examination. So I think we have to have a lot of patience. We have to have a good rapport with the child so that we are able to proceed and diagnose in well with the squint evaluation. So I think there are a lot of seniors who can give a lot of inputs as well.
Yes. One word from other panelists as well. Like, what made you take up pediatric ophthalmology, or what are the challenges? This is for the those who are considering pediatric ophthalmology as their future prospects, including Dr. Pooja, all of you. I think we can start with the speaker, Dr. Pooja.
So I guess patience is at most important because rather than the adult cases where you can finish it off quickly, they will understand your instruction and they will follow your instruction. That is not so the case in the pediatric strabismus evaluation. So I guess patience is at most important, and you learn that by time while examining. So if you approach the child as a friendly way, I guess they cooperate better.
Thank you. Then Dr. Aishwarya.
I think, yeah, as to add on to it, the amount of deviation is difficult to examine in children because you'll be planning your surgeries based on that. So that is one thing that needs to be done. So what I do is I need to reconfirm once or twice. So a single or two OPD visits are probably not enough till you get when the child is more playful, when the child is actually accommodating, using the target as the one that you've provided. So multiple examinations before you go ahead with planning and management of surgeries is something that I've realized is important in pediatric cases. Rest all, as everybody mentioned, you need to spend time, you need to be more with the child to realize, how a pediatric case needs to be worked out.
Just adding a note on that, I mean, as a general ophthalmologist, when I have a look at those tables, oh my God, really it makes me go bonkers because I really find it difficult to find a pattern in those tables about the number of of resection for the prism deviation of squint. I mean, just a general ophthalmologist
Yeah, I
perspective.
mean, hats off to all the pediatric ophthalmologists.
Really?
It's very confusing and it's not everyone's cup of tea, I would say.
Dr. Aditi, your 2 cents on this.
For the young ones who want to take this ophthalmology in pediatric, be prepared with a lot of patience and be prepared that you need to spoil your YouTube history because there'll be many shark do going on to make them really focus on what you are doing.
Take note.
Half the time there'll be one assistant sitting at your back with your phone holding with some videos playing. So yes, and the other is you need to get down to their level. You just cannot tower over them and examine them. You need to sit down at their level, be friendly with them, and they need to see when they're coming to you. They have been positive feedback is with them. You give them a chocolate or their way back, their parents get them an ice cream or something. Then they look forward to coming to you because they really need to visit you more often. For every follow up, every 4 months, 6 months, you need a good follow up with them.
Thank you, Dr. Aditi. Dr. Rasinama, your inputs.
I think previously pediatric ophthalm was not aware for everyone, but nowadays it is becoming an emerging field. And it is very nice, no? When people usually they come follow up every 3 months, 6 months, and every time they come, they're eager to visit us because we give a special toy. They are actually coming for the toys which we give, for the target which we show them, and for the videos which we show them. And when we give a better correction for their vision, also we also feel happy in that way. I think, but as everyone said, we should have so much of patience. We can shout to our own kids, but not to the kids who walk into our OPD. So we have to be extremely patient.
And final comments from Amrita ma'am. You've been seeing quite a few number of pediatric ophthalmology.
Yes. Yeah, as when I joined pediatric, it was by an accident. And as you told, I didn't like it for the first few months. I didn't understand anything. I didn't like it. I felt it is very difficult. But over time, it's very beautiful. It's a very beautiful field to grow. Only thing what you need is you should be able to tolerate kids and you should have a lot of patience. If you have these two things, you are fit to be a pediatric ophthalmologist because it's a emerging field. There is a lot of new things coming up with the increase in myopia and there is increased amount of squints what we see these days, and patients need more of cosmetic acceptance now. They want squint correction and patients are more aware of things now. So with this, I think we have a big future as a pediatric ophthalmologist. And moreover, a child, once you get to know a child, they always come and search for you. That gives a gratifying feeling. At the end of the day, you're very happy doing something good because just a simple toy or a simple reward is enough. It's not the same with the adult, I guess. So they're all good patients and it's quite interesting. Not every child is different, same like adults. It is all, every child is different and you're never bored when you're in the clinic. So I think it's definitely a good option to take up pediatric ophthalmology.
Thank you, ma'am. Thank you so much. I think the future looks bright as far as pediatric ophthalmology is concerned, and so ophthalmology. Over to Dr. Prasanna sir and Dr. Lippy. We've had, I think, very interactive panel discussion for both the residents and yours. Over to you, sir.
Thank you, Niranjan. Thank you, Lippy, for getting this webinar set in a very short time, as always. And thanks to the whole TNOA and Yosi team, as well as to our speakers and panel for taking your time. So we wanted to have these capsules in a very succinct manner. So we started at 7 and we wanted to end it at 8. So we felt this is the way forward, discussing one topic in a very, very short and succinct manner, so that the residents benefit a lot. And we also have this novel certificate distribution that we do at the end of the webinar, which starting from Dr. Pooja. Thank you, Dr. Pooja. It
Thank
was
you
very,
so much, sir.
I think my screen, yeah. Hope my screen is visible. So
Yes,
thank you
sir.
for being here. So as Dr. DC sir was telling, as well as our president, madam was telling. So the idea is to empower young ophthalmologists. And thank you for being here as a speaker, and your videos were very amazing. I think I also learned one or two about post-duction test today when you were demonstrating those videos. So thank you for teaching us today.
Thank you so much, sir. Thank you for the opportunity.
It's our pleasure.
I think that is also a very important take-home message for all of us about how to go about documenting videos for presentations. Thank you, Dr. Puja.
Yes,
Thank you, sir.
absolutely.
Thanks to again the dynamic panelists, Dr. Aishwarya Rathod.
Thank you,
Again,
sir.
thank you. We keep collaborating with you for multiple webinars, and you never say no to us. Thank you.
It's my pleasure, sir. Thank you.
Thank you, Dr. Aishwarya. Thank you, Dr. Aditi, for again taking time and being here in this webinar today and sharing your valuable expertise as well. Yes. Then we move on to the next panelist, Dr. Amrita ma'am. Ma'am, thank you, ma'am. As Nilesh was telling, Anand sir has really made a lot of difference in our lives. But thank you for being here for us again when it comes to pediatric and sharing your valuable insights today for young ophthalmologists out there.
Thank you. Thank you.
Thank you, ma'am. I think my screen is also getting a bit stuck. I hope the screen is changing. Thank you again, Rasina ma'am, for again being here and sharing your valuable expertise with us and the whole community of young ophthalmologists.
Thank you. Thank you for having me here.
Thank you, ma'am. With that, again, Dr. Shruti Ravi. Thank you, Dr. Shruti, for being here as again another panelist and sharing your inputs as well.
Thank you, sir. Thank you.
Yeah, and I'd be failing in my duty if I don't acknowledge Lipi and Niranjan. So a collaborative between two associations required two solid personalities to pool in resources, and Lipi really helped in getting the project streamlined in terms of Yosi resources. And Niranjan, your name is not here. Okay, Niranjan is part of the TNOA clan. So Niranjan again took care of all the base works from the TNOA side. So a big thanks to both of you guys. I think because of which my role is very limited and very easy. And we are able to keep this project running each month with new topics. And also special thanks to a lot of backend team, Numerotech team has helped with a lot of backend work and the designing work. Again, we have a solid designing team, Mr. Prakash and Niranjan, myself keep monitoring them along with Lipi with the backdrop and all these stuff. And again, thanks to TNOA and Yosi. So we will come back with another capsule as Dr. DC sir was telling, the Gulfstream slit lamp microscopy is going to be for the next month. With that, I hand over to Lipi and Niranjan for their closing comments before we close the event.
Thank you so much, Prasanna sir and Dr. Niranjan and the entire team of TNOA for including me in this collaboration. I would like to thank Dr. Pooja for a wonderful presentation and all the panelists for taking out their valuable time and for all the wonderful insights. Thank you so much, everyone. Thank you, Manjula ji, and the whole team of Yosi and TNOA. Thank you, Dr. Niranjan and Dr. Prasanna sir.
Thank you, Dr.
Thank you,
Lipi.
Lipi.
Thank you, Lipin.
I think this was a very short and sweet webinar, as what sir was mentioning. Each of you contributed fantastically, and I think the residents have their things sorted right now about Squint after this webinar. So a wholehearted gratitude to each and every one of you, and looking forward to collaborating more with all of you in the upcoming sessions as well. Thank you, ma'am. Thank you, sir.
Thank you. Thank you so much.
Sure.
Thank
Manjula
you.
ma'am, we can go off live. Manjula ma'am.
Okay, Doctor. Okay. One minute.